You're watching CTOM TV. Knowledge is power.
The question is, what are some alternatives to chemotherapy that work?
Well, chemotherapy is it's on its way out. What most people don't know about chemotherapy is based on plant phytochemicals, typically. They're called plant alkaloids, and they're the way plants fight against predators. And so they're usually harsh or strong tasting chemical compounds, and most of them are isolated from plants or fungi and molds and so on. And what they do is they prevent cells from copying themselves. So they interfere with the DNA copying process. And they typically do that in a cell cycle called M metaphase. And basically what they do is they will prevent every rapidly reproducing cell in the body from copying itself while the drug is in your body. Now that may be good for a rapidly reproducing cancer, but if the cancer isn't growing at that particular moment that you have that drug, then it's not going to be effective.
Okay, backing up. So how chemotherapy works is it stops all the rapidly reproducing cells from reproducing, which it means, again, hair,
skin, nails.
Right. So that's why we have these strong side effects with chemotherapy.
A lot of our organs are lined with skin, and that skin is rapidly turning over, rapidly reproducing. And what can happen is the chemotherapy will interfere with that, and then you can have stomach issues and nausea and so on. So there's a lot of side effects that happen from this process. The other thing is chemotherapy does not target the stem cells that produce all cancers. And we know that because when you have standard chemotherapy, your hair falls out and your nails are damaged. But as soon as you go off it, your hair starts growing back. And so that just shows you that the chemotherapy did not affect the stem cells in your hair roots, and therefore it's not going to affect the stem cells.
Right. If it's working on all of them equally, and those ones are still there and growing, then almost certainly your cancer cells are as well.
Exactly.
Yeah, wow.
So we haven't really developed any new chemotherapy drugs in a long time. Most of the chemotherapy drugs we're using today in Canada were developed in the 70s and the 80s, and some in the 90s, but we haven't really developed a lot of them now. All drug development these days is either immunotherapies, which target the cancer's process of shutting down the immune system and reverse that, or are targeted therapies, which target a specific genetic mutation. In other words, they will only affect the cells in your body that have that cancer-causing mutation. And that is the vast majority of treatments these days.
Right, so they're just, understandably, because of the problem you mentioned, they're not designing new chemotherapies.
Exactly.
But this begs the question, at least to me, why are we still using chemotherapy so much?
Well, chemotherapy can be very effective on decreasing the bulk of the disease. So if you have a lot of tumors in your body growing all over the place, they're going to cause problem and damage to the organs. They're going to be pressing against nerves. So when you get a massive dose of chemotherapy, most of those tumors are going to shrink down. Of course, they're going to grow back, and of course, they're going to come back. But it gives you some really good temporary relief, and it allows your body to heal a little bit from the damage of these tumors. Yeah. So we like to use chemotherapy as a last resort. And the reason we like to use chemotherapy as a last resort is because it does target any sort of cell regardless of the genetic mutations. If we can catch a person's cancer early on when they're first diagnosed, and we do our genetic testing and we identify the drivers of that cancer, then we can actually control that cancer for many, many, many years using targeted therapies and liquid biopsies. We just follow the mutations. As new mutations occur, we detect them with liquid biopsies, and then we bring in a different drug. And so we're turning cancer into a chronic disease rather than a terminal instant disease.
So manageable condition.
Exactly. Just constantly using different drugs. And because these targeted therapies only target the cells with that particular mutation, they don't affect all of the body cells, and most people can have very normal lives while on these targeted therapies. And You know, they can go back to work, they can do their bucket lists, they can do all sorts of things.
And have many more years of life.
And then when it finally reaches, you know, when we run out of targets, which, you know, is happening less and less because literally every day there's a new drug out. You know, with all those different studies, there's a new mutation being discovered and a new target for it. And, you know, all of the drug companies are trying to outdo themselves for each target.
Sure.
So once we run out of targeted therapies, then we say, okay, now let's hit everything with the chemotherapy. And that will get you a couple more years of survival.
Mm-hmm. Okay. So you said something, you're kind of rapidly in there about a process that you take your clients through to help them to have these extra years of good quality life. And it starts, as you mentioned, with genetic testing.
Genetic testing, yes.
You said something about curation of data, like these thousands and thousands of tests and everything that are coming out that your oncologist does not have time to read or to, you know, deep dive into and understand for your own case. You said targeted therapies. Tell us again how targeted therapies work.
Targeted therapies will target any cell in the body that has that genetic mutation.
Okay, so we do the testing and we find out what mutations you have. Right. Then we do some research. What's the point of this research?
To find out what the best drugs are in real time.
Okay, now, what's available?
Yes, so I can give you a perfect example with a case study if you'd like.
Okay.
So we had this lady, Sherry, and she's on our website, her case information. She was a young 50s woman who had lung cancer. So she was diagnosed with stage 3 lung cancer, and her oncologist did a spot test for her lung cancer. He said, you know, you've never been a smoker. You must have some sort of genetic mutation. I'm going to test you for this gene that I've heard of that we have some drugs for called EGFR, epidermal growth factor receptor. So he tested her and he found out that she had this mutation called the L858R mutation. And he put her on a drug that targets that mutation. He put her on a first-generation drug. So in other words, when the mutation first gets discovered, they create a drug. That's a first-generation drug. Then another company comes along and says, hey, we've got a better drug than that drug. It works better, it's got less side effects, and it kills more cancer cells, and patients live longer. That's the second-generation drug. Then another pharmaceutical company comes along and says, oh, we've got an even better one than your drug. So, you know, this drug is now a third generation, fourth generation. So she was put on a first-generation drug. And that drug typically gets you about an increase in about 2 or 3 years survival without needing chemotherapy. So she was literally able to have, 2 years, a chance of 2 years survival on this drug with no side effects or minimal side effects. And, hopefully that would be beneficial. So immediately after being on this drug, all of her tumors shrunk. All of her tumors went away or, shrunk right down. Her doctor was very happy with it. She was very happy with it. And she went back to work. She was a teacher. And she went back to work and started enjoying her life. And then her cough started coming back. So she called us. So the first thing we did was we looked at her information. We saw that the doctor had also done something called a PD-1 test that determines whether she would get immunotherapy or not. Now, we're not sure why he didn't give her the immunotherapy. I assume he was saving it for a later date, but she was highly positive for this marker, and she would have responded to this immunotherapy. It's considered, a last-ditch resort when really it should be the first-line therapy. And that's just because the Canadian medical system can't really afford to pay for these drugs. They're very expensive. So anyways, her doctor put her on this first-generation drug. Now, as it so turned out, she had some other mutations that limited the benefits of this drug. But those other mutations have been the subject of second and third generation versions of this drug. So we knew right away that if her cancer was coming back while on this drug, that she should have been given a third generation drug. And the third generation drug was actually approved. It's called Tagrisso, and it was actually approved 2 months before she was diagnosed. It was approved in Canada, and the Canadian medical system was covering it.
So it was available all that time?
It was available. The doctor just didn't know about it. And he's got his hands full.
That's so common, yeah.
So this drug would have worked for her perfectly, and she would have got many years of cancer-free benefits. Unfortunately, the Canadian government only approved it as a first-line treatment. In other words, it had to be the first drug you get, or you don't get it.
Whoa.
So by the time she found out about this drug, when we informed her about this drug, she had already been on this other first-generation drug, and the doctor wasn't able to give her this drug that would have saved her life.
Well, no. So could she have got access to that drug another way?
She would have had to pay for it out of pocket.
Oh, okay.
We also spoke with the drug company for her, and the drug company had agreed to cover the costs partially for her.
Yeah.
So what
great.
we did, what happens in EGFR mutated cancer is when these drugs stop working, there is a new mutation called the EGFR T790M mutation. And there's also another mutation called a MET mutation that can also cause these drugs to stop working. Tagrisso targets the mutation that she has, and it also targets this emerging T790M mutation. And there are drugs for MET mutations, yeah, definitely drugs for MET mutations available in Canada. So what we did was the problem is because it's an emerging mutation, it wasn't found in her original tumor. In other words, it occurred during her treatment as a cancer response to the treatment. In other words, the cancer said, hey, you're targeting us with this drug. We're going to create a new mutation that's going to get around that.
Now, how often is that the case?
That's very common.
Very common.
It's why most targeted therapies fail eventually. Is a new emerging mutation takes over.
So you have to be constantly getting genetic testing, or how do you know?
So the best way to detect emerging mutations is through liquid biopsies.
Okay.
Because the tumor cells shed their DNA into the blood. So if you go back to the original biopsy, it may not have that emerging mutation because the emerging mutation happened after that sample was taken out. And you can't keep going in there and removing tumors, and maybe that emerging mutation was only in a certain part of the lung, maybe it was only in a lymph node. By checking the blood using a liquid biopsy, you always find that mutation. So we tested her, and we found, and this liquid biopsy we did, at the time, her doctor said that she was still cancer-free. He had done a CT scan.
So she has a cough.
She has a cough. And the CT scan said that her cancer was negative. So what we did was we did this liquid biopsy, and we saw, number one, she did not have this EGFR T790 emerging mutation. So it would have not been a problem for her to get this Tagrisso. It would have still been beneficial for her. But it showed that she more than likely had this MET mutation.
Oh.
So she could have been given a MET inhibitor. So we went back to the doctor and we said, this woman is not in remission anymore. We found her original mutation at a very high rate in her blood. And he said, I don't see how. She has a CT scan. I said, well, here's the data. Obviously her tumors are very active right now. So then we sent her for a private PET CT, and the PET CT discovered that, yes, she was not cancer-free anymore, and that the drug had stopped working. Had she been on the original drug, the Tagrisso that we recommended that was just approved, she probably would have had about 3 years of remission, where in this case she only had about 8 months.
Oh, wow.
Yeah, so
that's a huge difference.
Yeah, so unfortunately, she developed, she was against vaccines. And she hadn't had her pneumonia vaccine, which is available for all Canadians. Every Canadian should get the Prevnar 13 and 23. It's a vaccine that prevents encephalitis and all of these like these drug-resistant forms of pneumonia that people are dying from in the hospital. And I know about 10 people that have died from this. There's no treatment for these pneumonias. They're antibiotic resistant, and so this vaccine treats against that.
Tell us again what the vaccine is called.
It's called Prevnar 13 and Prevnar 23. It's free. You get it at your pharmacy, and anyone can get it, literally. You just go to a pharmacy and get it.
And it protects you against these diseases.
23 strains. Prevnar 23 is against 23 strains, including encephalitis and some other horrible diseases. And the 13 protects you against 13 different strains. So that pretty well covers the gauntlet. it.
Right.
So unfortunately, she didn't get this vaccine, and she developed a treatment-resistant form of pneumonia and ended up dying from that before we could get her on a MET inhibitor.
So initially the diagnosis was off. The CT scan didn't pick up the cancer return, and lots of time was lost. And because of how the system is set up, she was not eligible for the treatment, although you were able to arrange
And her
some
doctor
access.
was really good. He, once he realized his error, he worked very hard to help her get that. He helped her get access. He said, yes, we can get you this MET drug as soon as you're over your pneumonia. So he worked, he worked with her and with us to really help get the best for her. He just wasn't provided with all the tools. He wasn't provided with the information that Tagrisso was indeed free.
Yeah. And again, even kind of the initial test and diagnosis.
Exactly.
Yeah.
Exactly.
Which is so often the case, is that, oncologists, their whole job is about doing their best to make sure their cancer patients get the best treatment and survive as long as they possibly can with minimal side effects.
And minimal tools.
Sure, well, that's it. The system,
minimal tools.
it depends on the system in which these doctors are working, what they're able to even recommend to you. And then depending on the system in which they work, they may have quite a large patient load, which prevents them from keeping up on the research. Again, no one person could keep up on all that research that Alex was talking about earlier, which is why...
We try.
Well, we have a team.
We have a team.
Yes, and that's the thing, right?
We go through about 60 medical journals every month.
Yeah, there's a lot of reading.
A lot of reading.
A lot of keeping up with things.
Thank you for watching CTOM TV. Subscribe below and stay informed.